going to focus more on the outpatient setting in healthcare, and we'll start to talk about some of the reasons that we're starting to see more of a shift from inpatient-based care in our hospitals to more outpatient and community outreach services. So historically, our hospitals and our care has been more hospital-based services where we think we have an inpatient stay, we're in the hospital for a couple days, and then we get discharged. But what we're starting to see is more of a shift towards our outpatient care centers. So we're seeing surgeries that you can go in, have the surgery, and be done in the same day and go home to your home to rest and recover instead of staying in a hospital for multiple days. And a couple reasons that we're starting to see that shift from hospital-based care to more outpatient care is we have a couple of advancements in technology that are letting us see shorter lengths of stay. We're seeing more of a shift to outpatient surgery centers. So think, for example, if you have a small children, usually what we're starting to see now is small children need to have tubes in their ears to relieve things like ear infections. Those things used to be done on an inpatient basis where the child would go into the hospital, have the surgery, and be in recovery in the hospital for several days at a time. And now what we're seeing is that is a same-day surgery done in an outpatient center, not even in a hospital, more of a surgical outpatient center. That surgery can be done same day and the child can go home to rest and recover. But we're also starting to see this from a cost efficiency standpoint. So we know the quicker turnaround times, the shorter lengths of stay is more cost efficient. It's more cost efficient to operate these smaller surgical centers as compared to keeping everything inpatient on the hospital side. And we're also starting to see a decline in our hospital occupancy rate because of this. So what does this mean from a hospital perspective? Hospitals are having to become more diversified overall. They're starting to get into the outpatient business. So if you think of these larger health systems, let's say particularly in this area, we have two main hospital systems as of right now in this area. Each have their own smaller outpatient private physician practices that are attached to them. So what this shift from inpatient to outpatient has really done has worked to intensify the competition that we see between hospitals and other community-based providers. So we used to have these smaller independent physician practices that we would see blanket our community. And now that competition has intensified because the larger hospital systems, because we are seeing a decrease in inpatient volume, are starting to do more community outreach, starting to do more outpatient procedures, and really working to intensify that competition between them and the local independent standing clinic. Now, there are a couple factors that have really worked to drive this shift from inpatient to outpatient. There's things like reimbursement, technology, which we've started to talk about, some issues with utilization of control factors, and then some social factors that we need to consider. So let's first start talking about reimbursement. So let's think about all the factors that go into reimbursement. Our public and private payers, which are our insurance, payment functions, our insurance companies, Medicare, Medicaid, overall, they're going to prefer more outpatient services. One of the main reasons that they're going to prefer this outpatient service piece is simply because it costs less overall for them to operate this way and for them to reimburse this way as compared to more of our costly inpatient charges. Overall, outpatient is going to be far less costly to our private and our public payers. So we also see some changes that have occurred in our reimbursement structure to our capitated payment system. So we have fee-for-service where services are paid as they occur. And then we have another type of reimbursement called capitated payment systems where insurance companies pay in advance a set amount of dollars based on how many patients are seen at a practice or hospital. And so we've seen changes to that kind of structure that's really necessitated the reasoning and the preferences for these third-party payers to pay more outpatient or to prefer outpatient rather than inpatient because of the cost effectiveness. Now, hospitals have really been given the reason to work to discharge patients quicker, which helped to create this market for outpatient services. And they've really been given the reason to start to develop these alternative service lines to help offset what they're seeing as a loss on the inpatient side. So remember, we said that we're starting to see a decrease in our inpatient admissions versus what we see going on the outpatient side. And because of this, hospitals have started to really try to become really creative and innovative in their service offerings, because now they have to offset what they're losing on the inpatient side. Technology is another big reason that we've started to talk about already, that we started to see this shift towards outpatient services. So when you think from a technological perspective, we're seeing new ways for procedures to be done, new ways for treatment and diagnostics. We're seeing less invasive surgeries than what we used to. We're seeing shorter recovery times that do not require hospitalization. So go back to the example of the kid getting the ear tubes. That used to be something that had to be done. It was rather invasive, had to be done in a hospital setting, in a surgery room where the patient could go to post-op, and then they needed to be an inpatient in the hospital for a couple days to be monitored and taken care of. But because we've had advancements in technology and the way we are able to do that procedure, it's less invasive now. We're able to turn around shorter recovery times. And we've been able to move this out of the hospital setting to our smaller practices that have surgical day centers set up to where patients could come in, get the surgery done, and leave and go home the same day. So really negating that need for hospitalization. The third reason we'll discuss is our utilization control. So payers have this preference to be more outpatient because of cost effectiveness, and the way they can steer their patients towards using more of these outpatient services versus being an inpatient in the hospital is through some utilization control and how their patients or how their subscribers for their insurance utilize services throughout the health system. So payers overall, they want individuals in the hospital as least as possible. Overall, mainly to decrease costs, because it's least costly to keep a patient in outpatient than versus inpatient. So they'll do some things like utilization reviews to make sure that the services are appropriate, and they'll also require something called a pre-authorization. So you have to get an authorization before you can start to seek this service. So they really work to for lack of a better term, discourage inpatient visits and really promote and tout outpatient services versus inpatient. And the fourth factor we'll talk about, and when it comes right down to it, the social factors. Overall, individuals, people, we don't want to be in a hospital. We want to go home. We want to, recover there and recuperate there. And so if we're given the choice overall, we want to avoid hospital stays. So we've really created this more individual preference towards the outpatient side versus the inpatient side. Now, there's various different types of outpatient services. They range from private physician practices to freestanding facilities. We have some home health care, long-term care, community health centers, mobile facilities. So we've got a wide array of different types of outpatient services that we can access, but we're going to focus in on two centered around the private practice and community health centers. So let's go ahead and get started with the private practice. Our office-based physicians have really been the backbone of this private practice structure. And what we've started to see historically, where they were independent freestanding, we've started to see a shift to form more from more solo practices to more group practices, maybe some that contract or connect with larger healthcare organizations. And the reasons for that being is really the uncertainty of the market in general and the healthcare environment overall. But being in a bigger organization as compared to a smaller grouping or a solo practice is that you have more contract leverage with this larger group structure. So you can, make more demands. You have more leverage in terms of contract negotiation when it comes to setting rates and reimbursement with your insurance companies and your third-party payers. Um, the competition that we've also started to see from these larger organizations, larger healthcare organizations that have entered the marketplace, have really necessitated the reason that these smaller and solo group practices have started to form larger alliances across the board. And then the really complex nature of the administration of practices and the burden that that carries. There's strength in numbers, so because of the high and complex nature of that, organizations, smaller practices have started to come together overall. So within private practice, the hope is to help to build this conceptual foundation of outpatient services that revolves around primary care. We know in this country, in our particular healthcare system, we don't place as much emphasis as what's needed on primary care. So let's take a few minutes to discuss what primary care is and the differences between primary care, secondary care, and tertiary care, and how that all feeds into our community health centers. So primary care services, you can think of these as more as basic and routine services, things like smoking cessation programs, health education, immunizations, employee safety programs. All these would be considered primary care. And then you move into secondary care, which is more sporadic. It's beyond the bounds of what we can see in primary care. And these are going to be things like our screening programs, high blood pressure screening and testing, mammograms. All these would be considered secondary care. And then our tertiary care level are going to be issues that are more complex, they're more intensive, they require some kind of specialty. So a person, a tertiary person who needs care is somebody with high blood pressure taking blood pressure medication, and the physician writes that prescription for blood pressure medication. That would be an example of tertiary care, and that's what we generally see our focus on in this country and in our health care system, is that more focus on tertiary care. And the hope with primary care is that we can go back to build what is supposed to be the foundational and conceptual structure of outpatient services with that spotlight on primary care. Now we have 6 domains or components that we need to discuss when we talk about primary care. The first one of those is primary care is really our point of entry into the system. So they work as what's called a gatekeeper into the healthcare system and really work as a control mechanism on how we access services. Primary care is also supposed to be very community-based, so it's supposed to be close to your home. It's set up to offer essential care, so it's available to the vast majority and really works to optimize our health. It gives us some level of accountability between our patients and our providers, so they work in conjunction with patient care. It gets the patients vested in their own care. And the final piece is that coordination and integration of care that primary care offers, or that we can start to think about. So primary care, very highly correlated with healthcare outcomes overall, and our primary care provider really works to be that hub of the wheel when we look at different types of care like specialty, inpatient, our diagnostic services, surgery. Primary care is right there in the center of all those, working as that gatekeeper and that coordinator of services. Now, because they do work as the gatekeeper and really the coordinator of care for patients, we see primary care and primary care physicians and people who seek out primary care services are more associated with things like fewer hospitalizations because they're receiving more primary and secondary care services. We see a decrease in ER or emergency department use overall. Which all of this can translate into lower costs of care. You stay healthier, you need less healthcare services, so that's going to reduce your cost of care. We also see a decrease in morbidity. So we see people getting more things like cancer screenings. We see a decrease in infant mortality. We see healthier birth weights. So overall, a lot of benefits, and particularly around reduced mortality when we look at life expectancy and stroke mortality. Now, because primary care is so important and we have all these great benefits that can come about from primary care and primary care services, we started to see primary care medical homes start to emerge. Now, these primary care medical homes, or PCMHs, really take their roots in the chronic care model. So we have an organizational approach that takes the provider, the patient, and a multidisciplinary team that work to make decisions together regarding health care. And we're seeing people we're seeing this interdisciplinary team rather caring for people and patients with chronic disease in this primary care setting. So we're really working to be population based here, taking care of people in more of a primary care setting, and it helps to work and create these more practical, evidence-based interactions between patient and provider. We have an informed, activated patient and a prepared and proactive practice team. So in the primary care medical home, similar to the chronic care model, again, we still have that multidisciplinary team structure with the primary care provider or the PCP as your usual care provider. They work on evidence-based practice and evidence-based guidelines to help coordinate some pieces of care and help deliver care. They bring in elements of health information technology, whether that's virtual visits, to help deliver and open up access to primary care. And they have some level of accountability for value and quality, and they can be very valuable, very effective, and relatively effective overall just through an evolution of the standard of care and a vision for the future of what primary care should look like. But we do have some issues that go with setting up this primary care medical home model. And one of those is, how do we coordinate a system like this, a great thought like this around primary care medical homes in our decentralized system of healthcare? So we talked about decentralization and how we face that in our health system today. So how do we start to work and put this focus on primary care when we're still working in a decentralized system? Community health centers are another way we can start to deliver primary care to our population, particularly in areas that we've deemed more of these health professional shortage areas, which we've discussed previously. So we see a lot of community health centers. These have been around really since the 1960s. They're called FQHCs, Federally Qualified Health Centers, and their primary objective is to deliver primary care to medically underserved. So they do things like primary care, preventive care, dental care, and they're really that critical component and that critical linchpin in our primary care safety net. So if you think about how many people we have in the United States right now, about 330 million people. We have about a fourth that are uninsured, half on Medicaid, and the vast majority are around 200% of the federal poverty line. Now, these CHCs, or community health care centers, they receive funding that's equitable and reimbursement that's favorable as compared to other entities, and their quality of care is, at or above at the average of most of the managed care organization benchmarks that we see, which is really great for these community health centers. They look at some disparities in access and different types of clinical indicators. And when we look at access nationwide, we see that with FQHCs, or our federally qualified health centers, we see that less with them than we do nationally comparatively, which is also really good. FQHC patients, they experience fewer ER or ED visits overall. They overall have less hospitalizations because they do put that emphasis on primary and preventative care services. But just like every other health entity out there, community health centers are experiencing some challenges themselves. Their Medicaid reimbursement rates continue to decrease, which makes things a little harder on them, particularly because their caseloads are increasing. Um, it's just a bad combination of the two. So you're getting less money, but your caseload is increasing. So how do you continue to provide this great quality care and access of services to your population when you're not getting the same amount of reimbursement that you're used to? Um, so uh, CHCs, or federally qualified health centers, FQHCs, had to implement and start doing something called a sliding fee scale, because people were coming to the clinic even though that they had insurance. So clinics started to charge on a sliding fee scale to kind of recoup what they were losing in reimbursement. So overall, we're really starting to see that outpatient services are starting to trend to be more than just our basic and our routine care. And we're starting to see more outpatient services offered in these ambulatory care settings. But because of the changes of reimbursement and technology, we're starting to see more ambulatory care service lines emerge. And also, our patient preferences and our population preferences have started to shift, which has caused this shift to outpatient services. It's an understatement to say that the focus we need to continue to place on primary and preventative care is really paramount to creating better and healthier outcomes for our patients and our communities. But overall, that's really going to be difficult considering the challenges that we in particular are facing as a healthcare industry, when we look at things like declining and changing reimbursement rates and structures, and really our anticipated shortage in our workforce overall.